And again, we do want to say that we were very much excited about what we have seen on the ground, which actually confirmed the presentations that were made to us yesterday. Because we are here on an oversight mission as the legislature of KwaZulu-Natal. Hence, we are here, a number of teams are deployed to various districts for 2 days. The reason being that as for the MECs and the departments to execute or discharge their responsibilities in different departments or portfolios. And for us to make sure that both the budgets and the APPs are met as per the mandate of the provincial legislature or provincial government of the province of KwaZulu-Natal. And for us is to make follow-ups and check whether those budgets are spent, but again, and check whether services are provided to communities. Hence, we are here on that oversight. And in this case, we then said we want to provide or do oversight on the Department of Health by having this health functionality program. So we saw the 3 clinics yesterday, and we were very happy indeed, I must say. We want to commend you, District Director, and your team, right from the district up to a level of an operational sister or in charge in a clinic, where what we have discovered is that all of those clinics are well managed as per our mandate. Because what we are talking about an ideal clinic, to say that what are the things that must be found in an ideal clinic to ensure that we are meeting the standards, especially as we are busy with the NHI public hearings. So we're very much excited about what we have seen on the ground. And for us, we said, we wanted to say that keep up the very good job that we are doing in the interest of our people, because for us it's not about ourselves, but we put the interest of our people before our own interest, because we are here to serve our communities. And this is the purpose of the meeting. And as we are now on our 2nd day, for these meetings, to get this debriefing from the district director, Dr. Shabalala, as I have indicated, who will be taking us through on a number of issues in terms of the broad overview, the district health profile, and so on and so on. So at this point, let me hand over first to Mshazi to introduce our delegation from the province, from the legislature, and then after that, Mshazi uzobe senikeza Dr. Shabalala, District Director, naye introduce a delegation from the district Amajuba. Immediately after that, Dr. Shabalala uzobe seqhubeka ne-presentation. Siyabonga.
Thank you very much, Honorable Chief Whip Zwede, and greetings to Dr. Shabalala, and the whole management of the district, as well as the colleagues from the legislature. From our side, it's myself as a Tembi Sonzuza, Senior Manager Committees at the legislature. And I have with me in the team, I'll start behind me. We have Uzethu Nyawose, who is in the office of the Chief Whip. Next to her is Cindy Ogamachana Wagatembe. She's the manager in the office of the Chief Whip. Sibeno, senior researcher, Unyambose Ustabiso. And next to me is Ulungisani Zondi, who is the coordinator at the legislature. Next to him is Uno Makwaza, who is the administrator for the research department in the legislature. Bese siba no Makujwa, Uputi Usmelane Esnaye from the office of the chief whip. And right at the end of this table is Mohammed Ismail, who is in our communications. Thank you very much.
Thank you very much. May I introduce the team from Amajuba district? I'll also introduce Mr. Hlomuga. I'll start with Mr. Hlomuga from Intergovernmental Relations, head of its Department of Health. Then from the district, I'll start on my left. This is Dr. Gustav Tom. The surname is Tom. Gustav Tom. He's our district clinical specialist. He's a family physician who's actually supporting the whole facilities, all the facilities in the district. We have Mrs. Zodwa Ntuli, the district clinical specialist team, advanced midwife, who's also overseeing quality standards in our primary healthcare clinics. Mrs. Tembi Nyaba, district clinical specialist member for pediatrics, ubhekelele ingane ke yena in the district. Mrs. Masuku, the owner, umphathi wase Danacol Clinic, uDoli Nkosi umphathi wase eThembalihle Clinic, uFatima Xulu umphathi wase eNgogo Clinic, uMrs. Keswa acting, uMrs. Ndaba acting deputy manager wase Madadini esibhedlela. Sukuma ubungekho izolo. Thanks. Mr. Vusi Khumalo uyena HR manager wase district office. Mrs. Khanyi CEO wase Madadini esibhedlela. Miss Dr. Nimbonile abangambonanga Dr. Fikile Mtshali umphathi wase Danhauser CHC. Miss Debongi Nkosi Khumalo deputy manager at district office. Umshazi bebe khuluma abashazi angibizi ithakazeli ngoba nama akekho uyangibiza ngaso. Mr. Nzuza umphathi deputy manager waka district planner at the district office. Mrs. Samgelisiwe Masango. Hayi ke uyo Trevor Manuel wala usiphathele imali. Yep, la at district office. Bese ngicela ukintroduce Usha Singh is from the Department of Social Development. Sisebenza naye. Ngisho ngoba izolo bengekho bebene provincial meeting akade be attendile bonke. I think I did not leave anyone. Okay. Then I can proceed to the presentation. Okay, I will sign. Bengicela ukuthi ngikhulume ngihleli phansi ngoba khona ngeke ngikwazi ukusitha abantu orana. This is a presentation from Amajuba Hospital, Amajuba District. Amajuba District has positioned itself as a learning health organization that is striving for continuous quality improvement. I think you can see that we subscribe to this. We know that we are not where we want to be, but we are continually striving to achieve quality standards. This is a journey for us. We are located in the northwestern corner of KwaZulu-Natal, bordering Free State and Mpumalanga, and we are actually occupying 8% of the provincial geographic area. And in our district, we have 3 sub-districts, that is Newcastle, Emadlangeni, and Tannhauser. Newcastle with 34 wards, Emadlangeni with 6 wards, and Tannhauser with 13 wards. We have N11 as the main transportation route, as well as R34. And this actually talks to the rate of accidents or injuries due to accidents that actually occur within our vicinity. In square meterage, the district is 7,902 square kilometers. 3,539 square kilometers is Emadlangeni sub-district, and 1,707 square kilometers is Tannhauser sub-district, and Newcastle sub-district is 1,856 square meters. And Newcastle sub-district is the economic hub for this. Mostly people that are working or where there is good infrastructure is in the west. So Newcastle is the hub of economic development in this district. This map actually portrays the size of these sub-districts. You can see from here that Emadlangeni actually in square meterage is more than Newcastle and Tannhauser put together, which shows that it is sparsely populated, which also poses a challenge with regards to service delivery platform. These are the demographics, but what we want to portray here per se, it is the population density per square kilometer, whereby it is 67 persons per square kilometer in Tannhauser, 10 persons per square kilometer in Emadlangeni. And then when you come to Newcastle, it is 196 persons per square kilometers. That shows how densely populated is Newcastle compared to the other districts. And that poses the problem for diseases that are associated with overcrowding and infectious diseases. With the estimates, it was estimated, we think it's still estimated because Newcastle is producing many children. It is estimated that there will be our population figure will be 572,008. It is estimated that there is a total population. Currently, it is 572,008. But we project that by the end of 2023, that is what is written in our IDP, that it will be 573. The implications for densely populated, as alluded to, it is making the community susceptible to communicable diseases. And for Emadlangeni, it actually shows that, the service coverage is limited because in Emadlangeni we only have 2 fixed facilities and only 1 facility is at the periphery. The other fixed facility, which is the clinic, is within the hospital. There are 3 mobile teams. And these mobile teams, ideally, we could be visiting them once a week if we had the resources. And there are other challenges that actually perpetuate this problem. They're actually, not in our favor when it comes to service delivery. Tannhauser has no coverage for hospital in Tannhauser, but they are referring to Newcastle and Matateni Hospital. This is the population profile for the district. The green is for males, the pink is for ladies. This shows, when you look at it, you can see that the pyramid actually becomes more slimmer as the years increases. But of note is that more males are dying. From 40 to 49, more males are dying compared to females. There is poor health-seeking behavior by men, which leads to early deaths, especially noted from ages 45 to 49 years. And we have actually developed some models to try and address that challenge, which will be addressed later. Then the life expectancy for men is lower than that of females. Hence, there are many households that are headed by females in the district. These are the social determinants. They are actually portrayed here according to the years of the reports. The percentage of population 20 years and older with no schooling. In 2016, it was 12.3%. So it means they were reasonably doing well. The percentage of higher education was 91% in 2016. Percentage of household with flush toilets connected to sewerage, 52%. The percentage of households with piped water inside dwelling in 2016 it was still 37.3%. Although we know in the area most of the taps are outside the actual. These social determinants have an impact on health. We like portraying them because health is not only a responsibility for the health department, it is a collaborative responsibility because of these social determinants of health, where other sector departments contribute to the improvement of the health status of the community. There is a high crime rate, substance abuse and injuries leading to premature deaths, especially of males. We know the things that are happening in our Osizweni area. You know, here there are pockets where we said, like Otembalihle, around those areas where we did not experience much crime. But we know that we have pockets where we know that crime is prevalent. There's high unemployment rates leading to diseases associated with malnutrition and vulnerability to communicable disease and mental illness. And uninsured population is at 88%. This actually poses a strain in our districts as service delivery platform because mostly people access services in the public health service. And even those that have medical aids, by September, they no longer have funds. So they come to the public service. So that depletes our resources as an organization. This is the health delivery platform. Here we're trying that what actually shows you where our facilities is. As we said that Emadlangeni is sparsely populated, it is big in square meterage, but there is only one dot and the one that is the hospital with the clinic inside. And in Danhauser CAC, we have 10 clinics. In Danhauser sub-district, we have 10 clinics and 1 community health center. Then in Newcastle, can you see they are so close to each other? These clinics were built before 1994. So the Newcastle is better off with regards to distance to be commuted to reach the clinics compared to Danhauser and West Emadlangeni. Health service delivery platform. The population, I've spoken to the population and square meterage and the hospitals that are available. For Newcastle, there are 13 clinics, Emadlangeni 2, Danhauser 10+1. The facility to population ratio in Danhauser, it is 1 to 9,780. Emadlangeni, it is 1 to 21,513. Newcastle, it is 1 to 32,666. If you actually check the summative part, it is 1 to 22,126. Mobiles. In Emadlangeni, we have 3 mobiles, and in Newcastle, we have 5. In the district, we have 8 mobiles. Then we are providing differentiated model of care. What do we mean by differentiated model of care? It's whereby we provide individualized care where we take the needs of the person into consideration. We ask a person, would you like to collect medication at the clinic or in an adherence club or in a pick-up point next to you? You know, we talk about things like that in differentiated models of care, whereby we provide specific services. For example, men's health. We have 2 high transmission areas. Those are mobiles. The name is just like that. High transmission areas where we find that, you know, the infectious diseases or whatever that is prevalent is higher there. Our high transmission area mobile actually visits the Chinese factories and the TVET colleges. We have 5 TVET colleges in this district. So those mobiles actually service those places. And we have 1 men's health mobile. We're trying to provide a differentiated care. We said earlier, men have a poor health-seeking behavior. So with this mobile, it actually provides a comprehensive service, but for men, and it is meant by male nurses to actually encourage them to talk, to be free when they are accessing the services, and not to have a headache when they are having something else when they visit our facilities. This is the referral pathway. We are actually receiving referrals even from the external stakeholders, the CPOs, the NGOs, the FBOs, hospitals, or religious sector. They can refer to our clinics. And we have clinics like Mdozo. Our referral system is structured in such a way that within that district, within that sub-district, you refer to the hospital within the district. As Danhauser does not have a hospital, so they refer to Newcastle and Matadeni because those are regional hospitals. But there, when you see in that orange block, we do have an exception. Ndozo Clinic is situated closer to Emadlangeni sub-district. So from Ndozo clinics, they can refer to Emadlangeni to Nimeya District Hospital for services if they need district level service. But basically all clinics, if it is anything has to do with a pregnant woman and a child under 12, they refer to Newcastle Hospital. But all other ailments, they refer to Matadeni Hospital. There is inequity in distribution of facilities because we only have 1 district hospital in the district, which is Nimeya Hospital, but it is situated away from people. So people cannot drive for 50 kilometers to access the service. Hence, our regional hospitals provide district level service as well as regional services and pockets of tertiary. Then we have private GPs referring to us. The CAC and the clinics referring to Newcastle and Matadeni Hospital, and Newcastle clinics also referring to Matadeni. So Nimeya, when Nimeya has a challenge which is not within their scope, they refer also to Matadeni and Newcastle Hospital. Then Matadeni and Newcastle refers to Grace Hospital in Pietermaritzburg. So this is how our referral system is structured within the district. Focusing on national health insurance programs, we have GP contracting. Currently, we are having 20 contracted GPs. We started contracting GPs in 2016, starting with 6. So we are increasing these GPs. In 2023-2024 financial year, we have 20 contracted GPs, except for the gateway clinics, because gateway clinics are within the hospital. So we do not send. It is the hospital doctor who actually supports them. An average of 3,500 clients are seen per month by these GPs. The district clinical specialist team is there, as introduced earlier. They are actually supporting the facilities in the district. We have ward-based outreach teams, 18 teams, The facility coverage is 84. And yesterday we learned those that were having incomplete teams, how they were working with other teams which have complete teams. And with the school teams, we have 10 teams. We need to replace the 2 teams. The process is underway. For centralized chronic medicine and distribution program, it is fully implemented in the district. There are 33,346 active patients and 32 pickup points established. And we pride ourselves, but at the same time, we are not happy because we started the decentralization into pickup points. We started a new pickup point here, but because you are not documenting, there is not documentation to that effect, but at least it is still functional, up to date, our initial pickup point. We have a pallet box at 5 of our primary healthcare facilities. A pallet box is like I'll show it. For ideal clinic realization and maintenance, Amajuba district is leading. Maybe I can pause. For ideal clinic realization and maintenance, Amajuba district is leading in the country. "19 over 26 facilities, that is 73%, are compliant with occupational health standards, isn't it? The certificate, they already received their certification numbers. They are awaiting their certificates. What does that mean? It means they are ready to implement NHI, 73%. And 1 hospital out of 3, that is Matateni Hospital, is ready to implement NHI. This is the pallet box. We said the pallet boxes are there in 5 of our clinics. It's like an ATM machine. The patient is told the date when to come and collect the medication. The medication is loaded here. The patient comes and punches and take off the medication. There is privacy. We are preventing long waiting times because a person can come after work and collect. They are within our facilities. And we can say that for now, we haven't had any vandalization. No one has tried to vandalize these pallet boxes. So these strategies actually have helped to decongest our facilities because not everyone has to come within the facility and be assessed. These are the human resources in our district. We have minimal vacant posts at management level. We are trying because governance is important. These leaders must be there. At the CAC, the post was advertised. We are about to do shortlisting. The other posts are filled. For Nimea, and that's why it's not right vacant because the medical manager becomes the CEO of the facility. The nursing manager is about to be finalized. The interviews were last week. So for PG, haven't done. These are the human resource forensic pathology. Because we have forensic pathology reporting to the district office, we are working as a team. So EMS here, we have a district manager's post that is filled. We do have challenges with vacancies under EMS. Sub-district managers, we have 2 vacant posts. Shift supervisors, we have 9 vacant posts. PPT, planned patient transport coordinator, we have 1 vacant post. When it comes to forensic mortuary, we have the clinical manager. We also have facility managers for our mortuaries. that are standalone, not those that are within the facility. This also just portrays the HRM capabilities per sub-district that under Emadlangeni, there are so many, and under Newcastle as well as under Danhauser CHC. For equipment and tools, we do have inadequate supply of computers, especially at PHC. We are still trying to source computers. The process is tedious. We do not have the competency of procuring computers as a district. We are reliant on head office with regards to procurement of computers. For vehicles, we have inadequate coverage of outreach teams by ideal vehicles because of delays in repairs. Our outreach teams have the vehicles that are suitable for the terrain, but because of the delays in repairs, they end up when their car is gone for repairs, then they will use a substitute car, which may not be optimal for that terrain. We have adequate essential equipment. Network coverage at PAC facilities 32.3, but there is inconsistent availability of the network. We think we have adequate vehicles to support service delivery. Had it not been for the delays in the repairs, we think we could manage. Challenges with EMS ambulances and aging fleet due to shortage. It just is used beyond the time. For support services, we have 487 community health workers. ICT, we have 5 IT technicians in the district, 1 for the district office, the other one for the CHC, and 3 for each hospital within the district. So we have coverage. It's an around time when you have a problem with your computer, there are people that are readily available to assist. There are therapists, physiotherapists, occupational therapists support our fixed clinics periodically. With infrastructure, there is limited
you.